Hello, and welcome to a short overview of options for treating substance use disorders. After taking this course, you should be able to know the difference between sobriety and recovery, identify 5 types of treatments available for substance use disorders beyond the historical 12-step model, list several of the principles of effective treatment, describe the best practice response to co-occurring mental health diagnosis and substance use disorder, understand the place of reoccurrence and effective responses to reoccurrence while in treatment or recovery, and identify the stages of recovery. Let me start with a question. Is the goal of treatment sobriety or recovery? Think about it for a moment. Are you and your client even reaching for the same goal? Are you both reaching for sobriety? Or is one of you reaching for recovery and the other for sobriety? In fact, what is the difference between sobriety and recovery? Let's begin by looking at a definition of addiction. Addiction is a treatable, chronic, medical disease involving complex interactions among genetics and brain circuitry, one's environment, and the life experiences that a person has. The American Society for Addiction Medicine emphasizes the chronic and neurological elements of addiction. What we often see is the behavior or the emotions that someone experiences or displays. We don't see what's happening in the brain. We think that what we're seeing are the choices that lead to addiction, when what we really may be seeing are the choices that are a result of the addiction. Once a substance use disorder has been established, the brain, body, and heart have been hooked, hijacked, and hacked. Changes in the brain are now driving behavior and emotions. Those with a substance use disorder will say that they do things they would never do or don't want to do. Witnesses to addiction will say their loved one isn't the same. Addiction has changed them. Well, of course it has. This is what chronic diseases do. So, stopping the use of a substance isn't enough. There has to be a healing or a recovery of the body, brain, and heart. Sobriety is the absence of a substance in the body. But sobriety doesn't include how we are sober, why someone's sober, or the daily maintenance that's needed to maintain sobriety. That's what recovery is. Recovery is the process of change through which individuals improve their health, their wellness. They live a self-directed life free of substances and strive to reach their full potential. Sobriety is what you stop doing. Recovery is what you start doing. Treatment can be thought of as falling into 2 broad categories: intervention types and delivery modes or platforms. Treatment programs arrange a spectrum of services and then deliver them through different platforms. Interventions can include behavioral therapy and mental health treatment, relapse prevention strategies, mindfulness, spiritual programs, trauma therapies, medical services, legal and vocational services. Delivery modes or platforms can be residential settings, outpatient settings, clinical settings, individual or group counseling, and mutual support group settings. Let's take a closer look at some of these delivery modes. Delivery platforms are designed around 5 key elements: what type of provider, what type of service, what kind of time commitment, what type of controls, and what is the location context like. First, provider type. Where will there be licensed professionals or non-licensed? For example, is this a C-STAR program with licensed counselors, or is this a sober living home where you have people working in there that have lived experience as volunteers or paid? Number 2, what type of service is that going to be offered? Is this a full disciplinary team with professional counseling, SUD counseling, mental health work, case management, vocational training, medical assisted treatment, and so forth? Third, time commitment. How many hours of treatment are planned daily and weekly? Fourth, controls. How controlled is the environment going to be? How much freedom to come and go is allowed? What kind of communication can happen in contact with past friends and family? What are the rules of engagement in treatment? In other words, what limitations are the client agreeing to when they come into treatment? And last, the location context. Is this a spa-like self-care facility? Is it a work program structure? Is this inside the Department of Corrections? Is this a farm or adventure setting? Maybe it's a church or religious facility. It's an office complex. And if it has a residential component, is it dorm-style lodging or bedroom lodging? When someone's substance use disorder is so severe that a controlled environment is necessary in order to stabilize the client, then inpatient or residential treatment modalities or platforms are used. There's 3 general types. First, there's the therapeutic community. These are highly structured programs where a client remains at a residence that often is more like a campus. These are usually 6 to 12 and even 24 months long, and they use what's called Milieu therapy, meaning every element of the schedule and of the lifestyle lived while on that campus is directed to being drug-free and bringing that disease into remission. These are most often faith-based organizations, or there are some that are embedded within the Department of Corrections. Secondly, which is the most common, are short-term residential treatment. These typically focus first on detoxification and then on stabilization and resolving all the immediate crisis. Then they provide initial intensive counseling in order to get the client through the stabilization phase of recovery and start early recovery. These short-term residential treatments are typically 1 to 3 months long. And then there is a residential modality called recovery housing, which provides supervised kind of short-term housing, meaning 6 to 24 months for clients that are trying to stabilize their employment, their finances, and their immediate supports like family structures, and they need a sober environment in order to do that in. When someone does not need a controlled environment in order to stabilize and begin recovery, then outpatient treatment is appropriate. Outpatient treatment is divided up into intensity levels based on the number of hours a day and a week that a client participates. The highest level is called day treatment. In this modality, the client will spend 8 hours a day, multiple days a week, but they will return home each day and 1 or 2 days during the week. The next level down, this modality is called intensive outpatient treatment, or IOP, and the client spends 9 to 20 hours a week in treatment. And then there's the lowest level, or the general outpatient modality, which is 1 to 9 hours a week of treatment. This is often on the evenings or the weekends. So as a client is able to sustain their recovery and move through from stabilization to early recovery to middle recovery, the outpatient level or intensity of care is lowered. So that was a look at the modalities or the platforms or the structures that interventions for treating substance use disorder are delivered. Now let's turn our attentions to specific treatment interventions that can occur at any of the levels of care or any of the delivery platforms. Let me walk you through some abstinence-based SUD therapies. First of all, I'll begin with the 12-step approach. This is a spiritual approach where clients surrender to a higher power, resolve resentments, change behaviors, and then practice a life of service and sobriety. Another one is Gorski's relapse prevention model. Gorski was a psychologist who worked in a hospital setting with chronic relapse clients. Gorski identified 9 things or stages or steps that someone goes through before they reuse a substance. And while these stages may happen rapidly, in the Gorski relapse prevention model, you learn to slow those processes down, identify when you're in which stage, and have an exit plan for each of those 9 stages before there is a reuse. Next is habit replacement therapy. In the last 2 decades, we have come to understand much more about some basic habits, and sometimes we refer to them as trigger habits that are recorded actually in the basal ganglia. The bad news is we can't erase those. This is one reason why substance use is a chronic disease that has to be put in remission. By using habit replacement therapy, we identify some habits and we make some changes. We replace a center part of a 3-part process of a habit so that those negative habits now can become positive habits. By doing some of this habit replacement therapy, we write over, we don't erase, but we write over in the basal ganglia new habits that are healthy and lead to remission of a substance use disorder. Another one is dialectical behavioral therapy, and I'll throw in there mindfulness therapy. This therapy and mindfulness are really focused on emotional regulation. You begin to not only manage your body's response to emotional stimuli, but your psychological response to emotional stimuli. This creates a margin, and in that margin, the client is empowered to usurp the impulse system or the addictive cycle in their brain and actually activate the executive function, the frontal cortex, which sometimes becomes hijacked, so they can empower the frontal cortex and their decision-making process so they are able to press through and have victory over addictive types of behaviors. Another one is eye movement desensitization reprocessing therapy, EMDR, often used with trauma therapy, but there are now some protocols that can specifically address feeling states or states of euphoria. And by desensitizing those and integrating other healthier beliefs, then the client is empowered to be able to live a lifestyle of recovery. One model that's been around for a long time is the Matrix model. This is the merging of psychoeducation, therapy, medication, mental health treatment, family services. It's kind of gives you a structure to merge all of these types of therapies together to treat the whole person. An important therapy approach is motivational interviewing. It's imperative that we connect values and behaviors, and we strengthen the connection between values and behaviors and support a client that is moving through the stages of change. Motivational interviewing is a very kind of structured and intentional way to avoid confrontation and empower the internal motivation of a client. And then there's 2 more new approaches. One is the contingency management. This is when you actually provide tangible rewards for abstinence and goal setting or goal achievement in a treatment plan. This could be in the form of monetary gifts, or it can be in forms of other tangible types of gifts that are given as they reach each of these stages of their treatment plan. And lastly, we've seen a real increase in medical assisted treatment. This is the use of medications to manage cravings and to reduce treatment withdrawals so that a client can engage in the psychosocial treatments that are available to them. Many times a client is experiencing a mental health disorder alongside their substance use disorder. Research shows that 40% of the time this is the case. We call this co-occurring. The best practice response to treating co-occurring disorders is to treat them simultaneously. Some of the most common mental health diagnoses that occur with co-occurring disorders are anxiety, depression, PTSD, schizophrenia, borderline personality disorder, cluster A personality disorders, ADHD, and bipolar disorder. When treating mental health in a co-occurring setting, there are some psychotropic medications that are contraindicated with those that have substance use disorders. Therefore, it's important that we have non-pharmaceutical approaches that both are evidence-based and practiced with a high level of fidelity. Here are our list of some of the common mental health and trauma interventions that can be used in a co-occurring setting. Some you're familiar with. There are three specific categories here that I want to just highlight. First is trauma. We know that trauma is at the base of a lot of substance use disorders as well as mental health disorders, so strong fidelity with EMDR or exposure therapies or trauma-focused CBT are important to utilize. There's another classification of therapies that are non-pharmaceutical. They're more neurological. In fact, sometimes they're used in occupational therapy. Cognitive rehabilitative therapy, interactive metronome therapy, audible beat stimulation therapy. These therapies actually work to enhance or to repair certain neurological functions of the brain that then affect both psychology and behavior of a client. Addiction is neurological. That's one of its core components. And therefore, it is very helpful to utilize these neurologically based therapies in treatment of both mental health and substance use disorder. And then there's I'm going to call the lifestyle therapies, mindfulness therapies, art and expressive therapies, and I'm going to throw in there even family therapies. These are ways of practicing life, therapeutic approaches that shape our practice of how we live. And they can be very effective as non-pharmaceutical approaches to treating a mental health disorder. Accumulated research dating back to the mid-1970s to present establishes some principles for any effective treatment program. Let's review them. First, addiction is a complex but treatable disease that affects brain function and behavior. No single treatment is right for everyone. We need to tailor it to the individual as often as possible. It's important that access be quick, that patients are able to engage in treatment at that point of readiness. Treatment that's effective addresses the patient's total needs, not just their drug use. It's also critical that a client stay in treatment long enough to establish a pattern of middle recovery. Treatment involves counseling and other behavioral therapies. Medications are often an important part of treatment, especially when combined with behavioral therapies. Our treatment plans need to be reviewed often. They need to be modified to fit the changing need of a patient. Treatment should address mental health disorders if they exist co-occurring with substance use disorders. Medically assisted detoxification is only the first stage of treatment, not the last. And treatment doesn't need to be voluntary to be effective. Lastly, drug use during treatment must be monitored continuously. Those that have a substance use disorder and those that witness a substance use disorder, as well as providers, can easily become discouraged when a reuse or a relapse occurs. We now refer to this as a reoccurrence. It's important to remember that reoccurrence in a SUD is at the same rate of reoccurrence of any other chronic disease, like diabetes or heart disease. We need to understand that reoccurrence is a part of recovery. It's a part of managing a chronic disease that must be put into remission. It is the first 6 months after treatment that reoccurrence is most apt to happen. That's the greatest time of vulnerability, as well as times of high stress or significant change. That's why ongoing care and mutual support groups are necessary to be established so that you can reduce reoccurrence. Lastly, note this about reoccurrence. There's a correlation between relapsing and the measure of recovery capital that a person has. Recovery capital are those internal and external resources. Most predominantly is someone's measure of hope, connection with other people, and meaning in life. These things impact reoccurrence significantly. If relapse is a part of the recovery process, it's beneficial to understand the very nuances and the details about relapse. In fact, I would suggest that you separate relapse from reuse, realizing that there are 9 things, as Gorski recommends, that happen in someone before they ever reuse. In fact, you'll notice that even people without a substance use disorder experience similar stages before they have a crisis moment. Here are the 11 steps that are involved in relapse: unhealthy emotions, state of denial, compulsive behaviors, and then triggers, an internal chaos, then external turmoil, the beginning of loss of control, addictive thinking then steps in, and then high-risk situations are experienced, and these then culminate in a relapse or a reuse. Taking this disease and putting it into remission requires that we respond to relapse not at the point of reuse, but long before reuse, to learn to slow the process down, to identify when we are in one of these stages, and then to know how to respond to that particular state of being so that the relapse cycle is subverted. So what do you do when a reuse or reoccurrence happens? First, be honest and complete about the details leading up to the reuse. Second, be willing to backtrack. Do the things you did before that initially moved you into recovery. Don't be afraid of repeating old things that worked. 3, increase your treatment. Be there more hours, and better yet, be there more days a week. 4th, increase drug screening. 5th, be open to additional treatment modes and therapies that you've rejected in the past. And lastly, make sure you consult with professionals and others that are in the recovery community. You can gain incredible insight and experience an enormous forward movement in your recovery after a reoccurrence. Throughout this training, we've talked about the phases or stages of recovery, so let me review them. There are 6 of them. The first one is transition and the last one is maintenance. But let me focus on stages 2 through 5. Stabilization, which is about a month to a 3-month period. Early recovery, which can be 6 months to 9 months of time. Middle recovery can be about a year of time, and late recovery can be a year to 15 months of time. And then a client enters into the maintenance stage, which happens for the rest of their life, because again, substance use disorder is a disease that is chronic and is only put into remission. Often we're asked, how long does it take for someone to recover? If you look at these phases or stages of recovery, you see that this could be a 2 and a 3 and a 5-year process of intensive work that then moves into a maintenance level. Throughout this course, you've learned the difference between sobriety and recovery. We looked at different types of therapies and platforms or modalities those therapies are delivered. We identified some of the principles that 5 decades of research has highlighted. We talked about the best practice of treating co-occurring disorders simultaneously. We talked about understanding the place of reoccurrence and how we can respond to reoccurrence in a substance use disorder. And we looked at the stages of recovery and what we can anticipate as a timeline for those that are living with this chronic disease.